Biopsy is being increasingly employed for pediatric tumors. Its use has been reported in the determination of lymph node status for several tumors in the pediatric population, including melanomas, sarcomas, and others. So the commonly accepted technique for localization prior to the sentinel node biopsy is lymphoscintigraphy. In this technique, the patient is taken to a nuclear medicine suite where a radiocolloid dye is injected intradermally. And you can see on the top figure with the high intensity signal in lymphoscintigraphy in the nuclear med scan, and then there's the associated lymph node basin. And on the bottom figure is the overlaid PET CT. In the pediatric population, this intradermal injection may have to occur under general anesthesia. Other drawbacks of lymphoscintigraphy include extra charges. So at our single institution, those charges can accrue up to $4,700. There's also a requirement of complex coordination of care between the radiology suite as well as the operating room. And as mentioned, the requirement of prolonged time under anesthesia in some cases. In addition, adjunctive blue dyes are used in order to assist with localization. These have known risks, with isosulfan blue having a known risk with hypersensitivity, and methylene blue being associated with skin necrosis. Therefore, we propose to evaluate indocyanine green as an effective alternative. In the figure here, you can see the primary tumor in the right lower extremity, and indocyanine green is a fluorophore that interacts with the lymphovascular system, and you can actually see it directly light up under a photodynamic display. And associated in the groin region, you can also see a green fluorescence. So therefore, we aim to characterize the use of ICG with the ultimate goal of obviating the need for lymphoscintigraphy. We evaluated 22 patients in total, and we sampled 63 nodes. We excluded the lymph nodes that were not hot, and so that left us with 50 nodes. We noted the external appearance of the main nodal basins fluorescently. Additionally, at the time of resection, we looked at the individual specimen status of ICG, blue color, and as well as the radioactive counts. So our main outcome was to evaluate the accuracy of ICG to detect lymph nodes compared to standard protocols. Anything that was listed as benign fibroadipose tissue or the like was considered a negative finding. In our descriptive characteristics, we noted a wide range of age. So our median age was 14.1 with an intraquartile range of 5 months to 37 years. The median time in the nuclear medicine scan was actually 112 minutes with an IQR of 1.5 to 2 hours. ICG was visible through the skin in 15 out of 22 patients, and out of the 50 nodes, ICG was positive in 49. The blue dye was positive in 27. Our primary tumor types were mostly sarcomas, melanomas, and squamous cell cancers, and our location of the sentinel node biopsy, as expected, was primarily in the axilla and the inguinal region. Our blue dye showed a sensitivity of 59%, and the ICG actually had a sensitivity to detect lymph nodes of 100%. However, this does come at a cost of specificity. So on the x-axis, on the right-sided figure, you see the false positive rate of the ICG is 75%, whereas the false positive rates of the blue dye detected no false positives, and so that was 0%. Of note, there was one patient who had no radiotracer uptake. We were able to use ICG to identify and sample the lymph nodes in this case. We additionally analyzed a subset of patients that were under the age of 5.5 years, and there were 5 patients. 4 out of those 5 patients actually required general anesthesia to undergo that intradermal radiocolloid injection and to actually obtain the lymphoscintigraphy. This resulted in a median additional time of under anesthesia of 89 minutes. And for 4 out of those 5 patients, ICG green was actually visualized directly underneath the skin, and for the one patient, it just was not reported in the operative note. So in conclusion, this is the first study examining the efficacy of ICG in sentinel lymph node biopsies in the pediatric population. We found it to be more sensitive than blue dye alone, and it may obviate the need for nuclear scan in select patients, and this may result in a reduction in time under anesthesia. However, our false positive rate was higher in ICG, and we actually can't do any head-to-head comparisons of the efficacy between ICG and lymphoscintigraphy, at least using this data, and we can't do a head-to-head comparison of time under anesthesia either. So for our future direction, we have accrued 40 total patients, so we'll be analyzing those further. And we'll be looking at the effect of BMI on ICG visibility, and importantly, we hope to compare cost effectiveness as well. And with that, I'd like to acknowledge Dr. Dasgupta, who's led the project, as well as Dr. Johnson, who is one of my co-residents, and the Cancer and Blood Disease Institute colleagues at the Cincinnati Children's Hospital. I'll take any questions.
Thank you very much for that presentation. Zach Kastenberg, Salt Lake City. I think ICG is a real game changer. It's had significant impact in terms of how we localize pulmonary nodules for a variety of metastatic processes. I've noticed that methylene blue oftentimes will interfere with our ICG imaging in that context. Did you find that the methylene blue was, in some cases, obscuring your indocyanine green?
In our case, we actually didn't use methylene blue. We used isosulfan blue. So we didn't notice any. There was no notes of whether or not it was interfering with it.
Okay, awesome. One follow-up, or additional question: how do you measure a false positive during a sentinel lymph node biopsy? Because absence of tumor does not necessarily mean an unsuccessful sentinel lymph node biopsy. Yeah. So I was hoping to be. Should have been more clear about that. So our false positive was if the biopsy, if the pathology specimen said benign fibroadipose tissue or benign fibrous tissue. If it was a lymph node, we consider that as the ability to detect it. Thank you.
Tim Laws from Lurie in Chicago. And Zach actually, first of all, great talk. Zach actually asked what was my primary question, which is what you meant by false positives. But just a couple other comments and questions. First of all, a very impressive number of ICG sentinel lymph node biopsy, certainly the largest ever reported, and so this is really valuable data. But why were you unable to compare the results of this with the technetium? Did you find that ICG? I guess I'm just wondering, were there any positive nodes that were picked up by ICG but not by technetium, or picked up by technetium but not by ICG?
Yeah, that's a great question. So we actually did analyze that data as well, where we didn't exclude the patients or the nodes that were not hot but ICG positive. And so we did look at that. And if you look at the sensitivity there, ICG is 95% sensitive, and the radio tracer is 82% sensitive. So it actually is potentially better, but the radio tracer is the gold standard. So that's why we decided to measure ICG up to the gold standard. I think future studies are going to have to do a head-to-head comparison, which is what you're suggesting, and we have some preliminary data on that.
Yeah, and then I think we'll have to figure out which patients you might avoid the technetium on, and that requires being able to see through the skin, like you said. And then I think for right now, probably only under about age 2 would you feel reliably confident about that.
Yeah, well, we have more data coming for those patients as well, hopefully.
Zishaan, really quickly, for everyone here, the administration of ICG, timing and route?
Yeah, so it's also intradermally, and the timing is immediately while they're prepping the patient.
So exactly the same.
Exactly the same as isosulfan blue.
Thank you very much.